Thank you. Can you hear me clearly in the back? Okay. So as before, a couple of ground rules. I'll never talk for more than 50 minutes without a break. If you have any questions, please let me know. That goes for the people who are attending remotely. I'll try to keep an eye on that as well. And then you've got an outline on one side of that page and then an evaluation on the back side. And we definitely want your feedback on this. Just leave the evaluation on the back table when we're done. So we're going to talk about infectious diseases, and the way that I would frame this is that this is not just about taking care of your patients, but this is about taking care of you. For all of us, our most important job is to go home safely to the family every night. And so as we go through this, I want you to think of questions that you have, think of cases that have come up, and think about how we can do our job as safely as possible, particularly as we get into the biggest and busiest season for infectious disease. So we're going to start off with some basic background information about the different kinds of microorganisms. So we are surrounded by bugs. There are bugs on our skin. There are bugs in our intestine. When we take lots of antibiotics and we kill off the bugs in our intestine, that can be a problem. So there are the normal flora that live around us, and then there are pathogens. And these can be the normal flora that, when they begin to cause disease, are then pathogens. That can be Staphylococci, Streptococci, Enterobacter. So staph and strep are common bugs that live on the skin. Enterobacter more often lives in the intestine. You can have viruses, rickettsia, and then you have opportunistic pathogens that affect people who are immunosuppressed. And so the normal flora are more likely to cause significant problems in people who are immunosuppressed. So the most common thing we deal with is bacteria. So some common bacterial diseases that we see are sinusitis, otitis media. Now, those are two things that we think there's a bacteria associated with that. We also know now that antibiotics aren't quite as helpful as we used to think they were. And so the guidelines for prescribing antibiotics for sinusitis and otitis media have definitely been walked back over the last few years. Bacterial pneumonia is definitely something we deal with in the pre-hospital setting. Unfortunately, we do also deal with pharyngitis in the pre-hospital setting. Tuberculosis is a bacterial infection, and we'll talk more about that. And then chances are you probably saw someone with a UTI, if not already today, at least on your last shift. So let's talk about how bacteria grow. There is a lag phase where there is slow growth. That's this flat portion of the curve. And then once they get used to the food nutrients in this habitat, then they start having exponential growth. So this curve shoots up, and then they're very successful, and then they start typically to compete for small, dwindling number of nutrients. That's the flat part. And then they often build up toxic waste products, and then the bugs begin to die. So that's the natural course of how bacteria grow. And you see this in your patients who are having bacterial infection. They may feel, feel a little icky, and then all of a sudden, the classic one is like a strep pneumonia. They just feel awful as the bacteria expand exponentially. This is often one of the things clinically that most often predicts this phase, where people have bacteremia, or an overwhelming amount of bacteria in their blood, or shaking chills. You've probably seen someone who has rigors, or not like I'm a little chilly, like their whole body is shaking, and that's this peak phase of bacterial growth. Just a little bit more background around bacteria. So we talk about bacteria in terms of how they take up a Gram stain. This was something that Dr. Graham came up with. And you'll hear people talk, oh, this person had Gram-negative sepsis, or this person has a Gram-positive infection. A rule of thumb is that Gram-negative stuff is below the diaphragm. And then gram-positive stuff is the stuff that's above the diaphragm and on the skin. That's a rule of thumb. Obviously, if you've got something that's on the skin right near the rectum, you can mix those things up. And then we also classify the bacteria just by their shape. So people might say this, this person has gram-positive cocci. That means that there are bacteria that take up the gram stain and they're shaped like a ball. So rods are more often gram-negative, so the most common one that we deal with is E. coli. E. coli is a gram-negative rod that lives in the intestines, and then they can be shaped like spirals. And the classic example of that is syphilis. Thankfully, not as common as it used to be. And then bacteria cause bad effects not just because of what they do themselves, but also what they release. So gram-negative bacteria release an endotoxin, something from inside the cell, during that cell death phase, and that's highly toxic. So the person who has a UTI and then crashes and burns all of a sudden becomes extremely hypotensive, very difficult to resuscitate. That's most often because the bacteria are then dying and then releasing this endotoxin. Exotoxins are the toxins that are released by a living bacteria. So the one common example of this is staphylococcal scalded skin syndrome, or SSSS. And so these are patients who have some kind of staphylococcal infection. This can come from something like toxic shock syndrome, or it can come from a skin infection. And the living bacteria produce this exotoxin, and that can make people extraordinarily sick. Clinically, this looks like someone who's got really red, really flushed skin, and is really hypotensive. So viruses are obligate intracellular parasites. They cannot make their own energy. They can only live within cells. They can only live within cells. So all their growth, all their reproduction is within the host cell. Now, viruses also can go through very rapid replication. And so anyone who's ever had the flu or had a cold that really came on quickly knows that feeling. Whereas bacterial illness tends to be focused most often in one part of the body. So either you have a pneumonia or you have a UTI. Viral infection goes all throughout the body. And so the people who are saying, well, I'm throwing up, I have diarrhea, all my muscles ache, I've got a headache, my hair hurts, those are people who most often have a viral infection because it affects all of the body at the same time. Now, this can be difficult to differentiate from bacteremia because that's a disseminated bacterial infection, but much more often people with a viral syndrome have symptoms all over their body, whereas bacterial infection is localized to one part of the body. So there are other microorganisms that are less of an issue for us, but still do come up. So prions are small particles that are normally in the central nervous system and can cause the disease. What are some examples of prion diseases? Mad cow disease. And what's something that we have here? Yeah, chronic wasting disease in elk. And so this has been described generally as long as you avoid eating stuff from the central nervous system of your elk, you'll be fine. Fungi are things that affect all of us. That's athlete's foot, jock itch, but particularly in immunosuppressed people, fungi can cause bad invasive infections. One example is mucormycosis in a diabetic, where they get an invasive fungal infection in their nose. And so what might be look like a typical sinusitis on the outside, we have to take much more seriously in someone who is immunosuppressed and especially diabetic. And then there are parasites. So these are something that are more common in the developing world, but we still deal with here. This is Giardia lamblia, what causes beaver fever. And so that's typically a foamy, profuse diarrhea. Entamoeba histolytica cause liver cysts. The helminths, the worms, so something that we definitely do deal with here are pinworms. That's most often like really intense anal itching in school-age kids, and occasionally a school will have an outbreak of that. Hookworms and trichinosis are less of an issue here. One protozoan disease we do see here is cysticercosis. So the pork tapeworm can, if you're eating undercooked pork, especially if that pork is living someplace where it can get in contact with human feces, it can form little cysts in the brain. So it's a common cause of seizures in immigrants from Latin America, who are especially people who are coming from more rural areas. And it's not uncommon to see someone who has a first-time seizure in their 30s or 40s. You CAT scan their head, and they've got these little circles in there from the tapeworm making cysts in their head. And then we've obviously got ectoparasites like lice that don't get inside the body but just infest the outside of the body, and unfortunately the ambulance sometimes. Okay. So now we're going to move on to talk about how disease is spread. Any questions about the last section? I'm just going to check. Okay. Yeah. This sounds off. How about that? Okay. So the transmission of infectious disease is an interaction between the host, the infectious agent, and the environment. So we've already talked a couple of times about how immunosuppressed people are more likely to get infectious disease. The infectious agent can vary, for example, what strain of the flu we're dealing with, and then the environment. So there's some bugs that thrive more in dark climates, in warm climates. It affects what reservoirs the disease has. So for example, influenza is where we often get new strains of influenza is from Southeast Asia, because you have people who farm both pigs and ducks. And so there's swine flu and there's bird flu, and they have a chance to mix and come up with new kinds of influenza. And then you can have direct transmission or indirect transmission of an infectious agent. So obviously one of the routes of exposure we're most concerned about is bloodborne. We'll talk a little bit more about specific bloodborne diseases. We're also obviously concerned about airborne transmission. Sexually transmitted diseases have never gone out of style, and still are an issue, and are becoming more of an issue because we're getting more drug-resistant sexually transmitted diseases. Fecal oral transmission, I think, is best described as a surprisingly effective way to spread disease, and still is, and we'll talk about diseases that are spread like that. And then there are foodborne diseases. And you can talk about the theoretical risk of infection, meaning how might this affect you, versus what can you measure, how many people are actually getting sick from this infectious agent. Other things that affect, we talked a little bit about mode of entry. What does virulence mean? I heard how strong its ability is. Right. So virulence, so there are some, so take for example Ebola. Ebola is extraordinarily virulent. It has kills about 90% of the people that it infects. That makes it harder to transmit because people don't walk around carrying the disease for a long time. They die fairly quickly. So very virulent diseases are typically not as transmissible. When we get into problems is where you have something that's fairly easily transmitted, like a pandemic flu or like SARS, that's also fairly virulent. So the number of organisms transmitted, so that can, the difference between a needle stick where you have maybe a hollow point needle, say that a surgeon was sewing with, a solid point needle that a surgeon was sewing with, is not going to carry as many organisms as a hollow point needle that you were using to draw blood, and that carries a lot of blood that has that organism in it. Different people have different levels of resistance to certain diseases. For example, there's some people who have been found to be at extraordinarily low risk for getting HIV. And then there are other host factors like general immunosuppression that affect how likely someone is to get infected. The infectious process goes through different phases. So there's a latent period where you're infected, but you don't have signs yet. You're not transmitting the disease yet. Often that then comes into a communicable period, sometimes even before you have a lot of symptoms. So pertussis, for example, is something like before you really get into the painful paroxysms of cough, the whooping cough that lasts for a long time, you're communicating the disease. Then there's an incubation period, and then there's the period where you're sick. So take the common cold. There may be a time where you're around some other people who have the cold. You see, you rarely get sick at the same time as other people in your family. Then there's a period where you're starting to have runny nose or sore throat, and you're communicating it. And then there's this incubation period where you may not feel too bad for a little while, and then the disease period. Okay. So now we're going to move on to talking about the body's defenses. So we have natural defenses, intact skin, and the respiratory system naturally filter disease. And then we get into the specialized defenses that the body has. And the reticuloendothelial system is what identifies foreign material and then triggers an inflammatory response to that, for the things that get by the initial barriers. The leukocytes, or your white blood cells, are part of that initial defense. And then you can have cell-mediated immunity or humoral immunity. And so the important association to make is that humoral immunity is what results in the formation of antibodies. So this allows you to have memory for a certain infection and for the body to specifically target that infection. Antibodies are also called immunoglobulins. You'll hear people talk about IgG, IgM, IgA, IgE. The specifics of that are less important to know than knowing that's what triggers your body's response. The one we deal with most in EMS is IgE. What's a pathology that we often see that involves IgE? Anaphylaxis. So IgE is your rapid response. And so autoimmune diseases also involve these immunoglobulins. So another way of looking at the immune system is to look at how it fights infection. So the complement system is basically a way of amplifying the signal that you get from that antibody to ramp up the fight against disease. So, for example, it can recognize some of the endotoxins and then start to attack those. The lymphatic system includes the spleen, the thymus, lymph nodes, ducts, and that's where the white blood cells will do a lot of the attacking of bacteria, the phagocytosis, where they're eating the great song. And so that's where that happens. So what patients do you see that have, what are patients who have impaired function of the spleen? HIV? Who else? So obviously you'll see kids, for example, who were in an accident and got a splenectomy. That's part of the reason that the surgeons do a lot fewer splenectomies on kids than they used to. But kids who don't have a spleen, or adults who lost their spleen as kids, have less of that. Patients we see less frequently here, but still do exist. Patients with sickle cell disease usually effectively lose their spleen by about age 5 or 6. And then, so a little bit more about antibodies. Antibodies are what provide your individual immunity. So passive immunity are what you get from maternal antibodies. Active immunity comes either from immunization or from direct exposure. And that, for some things, for example, hepatitis B virus, we can measure whether you actually have the antibody to it by getting a titer. And so that's where you seroconvert, where you actually have the antibody that will work against that. That's called seroconversion, and it's measurable with a titer. So now let's talk about infection control. So the idea with infection control in the pre-hospital setting is that we're trying to interrupt this circle at one of several different places. So we have very little control over the infectious agent, the virulence. We can't affect the dosage that we're exposed to by doing things like using masks, using gloves. We can be aware of the means of transmission, aware of the routes of exposure, and then there are things that we can do to make ourselves less receptive hosts for disease. So this is, as Mark alluded to, this is a training requirement, and it must occur annually. Do you remember how many pages total this was? Yeah. Double. And the WAC, the WAC that, yeah. Right. Multiple. It's over 10. We're boiling it down here. Right. So we're going to talk about the phases of pre-hospital infection control. And then after we'll go through this, and then we'll take a quick break before we get into the specific diseases. So we prepare for response with written procedures, with an infection control plan, the training that you're getting here, the equipment that you need, making sure that your personal wounds are bandaged and treated before you respond to an emergency, using disposable supplies. Part of preparation is making sure that you have a place where you can at least foam off before you're dealing with foam, or use alcohol wipe before you're dealing with the patient. When you have an active infection, to not be delivering patient care. We also are monitoring for compliance with vaccination and diagnostic tests. Your agency will have a designated infectious control officer. I think we've successfully identified the jobs and processes where the possibility of exposure exists, and then you get hazmat education as well. So in response, what are some issues that you've had in responding to patients who have infectious disease? What's that? Yeah. So often patients don't know, and so we need to have a high index of suspicion that we might be walking into a place where someone's dealing with an infectious disease. You may get some clues from the notes, but we all know that dispatch information is limited. Was there another question? Okay. So then as you're going into patient contact, isolating body substances, so that can be something that someone has thrown up, wearing your PPE, limiting patient contact to the necessary personnel, using adjuncts for assisted ventilation, and then as before, using disposable items. Properly disposing of your biohazardous waste, especially not doing things where you are handling your mucous membranes in the same areas where you're providing patient care. So I'm not going to ask for a show of hands for this, but just think, how often do you actually wash your hands after every patient contact? And I think this is something that's definitely changed in healthcare. That's something that we will get watched in the hospital, and occasionally there'll be little spies that come in and see how often we wash hands. We're not great at it, and we can do better. And we do know that when we do better, we have fewer transmitted infections from patient to patient, but we also lose fewer sick days for your providers. So this is something that you can do to keep you healthy, keep your family healthy. So you're going to place infectious waste in leak-proof bags, decontaminate the contaminant clothing and equipment, and deal with your uniforms as per policy. So when you're dealing with someone who has an infectious disease, and we'll talk about specific diseases and specific decontamination risks that you should be concerned about. So routine disinfection would not destroy Mycobacterium tuberculosis, which causes TB. Intermediate level disinfection using bleach will destroy TB. High level disinfection is something that's rarely used in the pre-hospital setting, and then sterilization is something that you would use, for some reusable piece of equipment. For example, some of the laryngoscope blades that we'll use in the hospital get re-sterilized. So why don't let's take a 5-minute break now, and then we'll come back and talk about the specific infectious disease. So I'm going to start off by talking about HIV. So HIV is found in blood products, body fluids. The most common way it's transmitted is sexual contact. The fastest growing group of people who are getting HIV are heterosexual people. Shared needles is obviously definitely a risk factor. So transmission to healthcare workers is fairly rare, but still does happen, most often because of accidental needle sticks. As we talked about before, the high-risk exposures for HIV are the ones that have a large volume of blood, a deep percutaneous injury, an actual IM injection, or someone who has a very high viral load as the source. So let me see a show of hands. How many of you have taken care of someone with HIV in the last month? Right? And do you think, as compared to 10 years ago, is it easier to clinically identify someone who has HIV or harder? Harder. Why is it harder? I'm sorry? Good drugs, yeah. I mean, it's really changed. So at the risk of dating myself, I got my EMT basic in 1992. And I mean, then it was almost, it was barely treatable, but almost a certain death sentence. Now it is really a chronic disease. And so you're less likely to see a lot of these things that we associate with advanced HIV. It's less, whereas 10 or 15 or 20 years ago, you could see someone who was extraordinarily thin, had the dark spots of Kaposi's sarcoma, and you could say that really looks like someone who has HIV. Patients who have HIV clinically appear much more like patients who don't have HIV than they used to. There are exceptions, and the patients who are off their antiretroviral drugs can certainly look like that. Luckily, the patients who look like that are the patients who have the higher viral load and are a higher infection risk. So HIV can present, you can have acute HIV right when you get it, which is like another viral illness, but it's a very intense viral illness. And then you get the chronic acquired immunodeficiency syndrome, where you get these secondary opportunistic infections, you get the weight loss, and then later on you get the dementia, psychosis, peripheral neurological disorders. And these are much, much more rare than they used to be, because this is essentially managed as a chronic disease now. So if you are exposed to HIV, you'll get seen typically initially in the emergency department, and depending on the risk of the exposure, we'll talk about whether or not to do post-exposure prophylaxis. So it is the post-exposure prophylaxis. These drugs definitely do have side effects. There is a downside to getting the prophylaxis, but it's definitely something that we'll do if the exposure has a significant risk. And so if you're seen for that, we can counsel you about the specifics of how high the risk is from your exposure versus how high the risk of taking the therapy is. Questions about HIV? So hepatitis, especially hepatitis C, is far more likely to be transmitted to a healthcare worker than HIV. So hepatitis in general appears similar regardless of what kind of infection. Acute hepatitis presents, again, as a viral illness, but with the addition of right upper quadrant abdominal pain, and then these specific findings like having jaundice, clay-colored stool because the bile that you would normally be breaking down, you're not breaking down and excreting in the stool. You're getting this very dark urine, again, because you're not excreting your bile in the stool. And so you've probably seen end-stage liver patients, and they tend to look, they don't have the big ascites, but acute hepatitis, these patients can look very, very jaundiced, and they may describe this clay-colored stool, and they typically look pretty ill. So hepatitis A, viral hepatitis, is another one of the fecal-oral diseases. It's typically self-limiting. Many patients are asymptomatic. So these are the outbreaks of hepatitis that you hear about. The most recent one, there was a Townsend Farms in Oregon was putting out an organic supplement, and the pomegranate seeds that they got from Turkey had hepatitis A in them, so some people were getting sick. But this has also been described in certain restaurants where if you have a worker who has that, it can get into the food. Hepatitis B is transmitted either through blood or sexual contact. So you can, somewhere between 5 to 35% of all needle sticks from someone infected with hepatitis can result in infection. So that's why hepatitis B vaccination is something that we recommend everyone has. And this is one of the ones that you can get a titer to make sure that it was infected, that it was effective. You may have, because in addition to people who know they have hepatitis B, there are also a large number of people who have the hepatitis B virus as a carrier but don't know about it. So that's why this is such an important vaccination to get. Hepatitis C is primarily IV drug abuse and sexual contact. This is probably, because there is no vaccine for this, this is one of the most common things that can be transmitted by needle stick. And that's why, you've probably heard this before, I'll reiterate it, but when you're handling a needle and anyone is potentially infected, it's like handling a loaded gun, because hepatitis C is a potentially life-altering illness that can be transmitted with a needle stick, and there's not a vaccine for it. You can try post-exposure prophylaxis. There are some treatments for it. This is it's something you don't want to get, very difficult to prevent and treat if you are exposed by needle stick. Hepatitis D goes along with hepatitis B virus. It's not clinically important. And then hepatitis E, very rare in the U.S. It's a foodborne illness like hepatitis A, but from contaminated drinking water. Questions about hepatitis? So tuberculosis worldwide is the most common preventable infectious disease. As with other bacterial infections, we are running into drug-resistant tuberculosis. And so what has to be true for someone to spread tuberculosis? What does the patient have to be doing to spread tuberculosis? Cough. So although you can have latent TB, you're only spreading tuberculosis when you have active tuberculosis. We'll talk about what that looks like clinically. So skin testing looks for exposure to TB, latent TB. TB most often is pulmonary TB, although it can be either disseminated, it can form a tumor in the lungs, but it can also form a tumor in the vertebrae. That's called Pott's disease. We have tuberculosis of the spine. Far and away the most common is tuberculosis in the lungs, pulmonary tuberculosis. So clinically, this looks like chills, fever, fatigue, chronic cough, and weight loss. Night sweats are common with this. Hemoptysis is common with tuberculosis. Now, there are many other things that cause hemoptysis, but these things together, weight loss, night sweats, hemoptysis, should make you concerned about the possibility of tuberculosis. Who is at risk for tuberculosis? Yeah, incarcerated. Tuberculosis is very prevalent in prisons in particular. Who else? It can happen anytime you have people crowded together. And someone's got active TB, that increases their risk. Immunocompromised, absolutely. And HIV and TB together are a deadly combination because the HIV makes them more immunocompromised, which makes them more likely to get active TB and to cough that up. What other patients that we see on a routine basis, besides patients who have been incarcerated? The homeless. And tuberculosis is unfortunately more common in homeless shelters. So the times to think about it are when you've got any of these things, the cough, the weight loss, hemoptysis, night sweats, in someone who is at risk. So if there's any concern, I would recommend that you wear an N95 mask, and then you'll get, as part of your job, you'll get routine post-exposure identification and management. So if you convert, so say you go from someone who had a negative PPD, a negative skin test, to a positive skin test, like this raised red bump that you show here, then the recommendation is that you go on a drug called isoniazid for 6 months. Among the other downsides, you can't drink while you're on this drug. So safety first. Is the best way to avoid transmission of tuberculosis is to avoid exposure, and if there's any concern, to wear an N95 mask. What difference does it make to the hospital if someone's at risk for tuberculosis? What kind of room would we put them in? Yeah, isolation, negative pressure room. So it's certainly helpful to the hospital. You say, and you can just tell us the situation, and we'll figure out what to do with it. But if you say, I've got someone who is who's coming from the jail and who's had a productive, cough with hemoptysis and night sweats, that's definitely valuable information in the HERE report, and we'll get a negative pressure room ready for you. So pneumonia. So most common, we deal with bacterial pneumonia. Sometimes this can be difficult to differentiate from CHF. Obviously, things like fever, sudden onset, a focal infiltrate on their lungs make you more concerned for pneumonia. What patients are at risk for acquiring pneumonia? Elderly. Who else? Yeah, bedridden. So anyone you have, just by being in bed, often people who are in bedridden are in a facility where you're exposed to other bedridden people and sick people. So people in care facilities, people who are bedridden, are at higher risk for pneumonia. Who else? Smokers, yeah, there's nothing about smoking that helps you fight off pneumonia. So smokers are at definitely high risk. But who's more likely to aspirate? What patients are at risk for aspiration? Say that again. Stroke patients. So stroke patients who've had a prior stroke, definitely at higher risk for aspiration. Who else do we see frequently who's at a high risk for aspiration? Vented patients, or Alzheimer's. What about patients that are found down? Patients who are inebriated definitely are high risk for pneumonia, especially aspiration pneumonia. So But as with a urinary tract infection in geriatric patients, they can sometimes provide you less history, and it may just show up as altermentation. Obviously, the combination of altermentation plus fever and/or hypoxia makes us very concerned for pneumonia. So obviously, you're going to provide oxygenation and ventilation. Consider TB and ask those questions about whether you've been incarcerated, whether you've been homeless, and then think about masking yourself plus the patient. So with exposure to a pneumonia, there's unless you're over 65, you don't need routine vaccination against pneumonia. But and this is not something that we typically do post-exposure prophylaxis, because most healthy people are not more likely to get pneumonia after taking care of a patient with pneumonia. So chickenpox is caused by the varicella zoster virus. So the varicella zoster virus causes chickenpox, which is an acute infection, and then causes shingles, which is reactivation of a latent infection. So chickenpox typically has respiratory systems, malaise, typical viral infection, and then low-grade fever followed by a rash. Occasionally you'll get the rash as the first sign of illness. Transmission comes through the droplets that the patients are coughing up, and then you can have direct contact with the lesion. In adult immunocompromised patients, this can be a very serious infection. So as far as assessing your immunity to chickenpox, if you've been exposed to it, then that's considered enough. The CDC actually considers being born in the U.S. before 1980 sufficient exposure, just because it was so common. But you can be immunized against it, and then obviously you're going to take your universal standard precautions. And if you've not been exposed to it, then you should get post-exposure vaccination if you care for someone who had this. So meningitis is another disease like HIV that has really changed how it shows up. With HIV, it's because we have good drugs to treat it now. With meningitis, it's because of vaccination, especially the pneumovax that both kids and elderly patients get, and then influenza immunization has definitely changed what kind of meningitis that we're seeing. So you can get bacterial meningitis. That's what we're most worried about. So streptococcus, the same streptococcus, the strep pneumoniae that causes pneumonia, can also cause meningitis. And then Neisseria meningitidis, which is also called meningococcus, can cause meningitis. That's especially in kids. Those are the patients that who look really ill, develop this purpuric rash. Thankfully, that's become much less common. You can also have viral meningitis, and occasionally we end up doing spinal taps on people just to find out that they, in fact, had viral meningitis. But that's almost never treatable. It gets better on its own. So transmission factors that make meningitis more likely. So it's more likely to be transmitted during the winter. Obviously, anything that makes you more susceptible to infection can make you more susceptible to meningitis. It's passed through contact with oral secretions, and again, smoking makes you more likely to have it. Where we do see it these days are in college dormitories, or we'll see it with military recruits. Patients that are crowded in a close setting makes it easier to transmit meningitis. So there's typically an intubation period, and then you have these fever, chills, headache, stiff neck, and then in the worst case, altered mental status, vomiting, seizures. The Brudzinski's and Kernig's sign are signs of inflammation of the meninges. Basically, if you are one is lifting a leg, and that causes the patient to bend their leg because they don't like the meninges to be stretched, and the other is to lift the head, and then they bend the leg for the same reason. So we talked about how immunization has really changed how often this disease shows up. But where you are at risk is if you take care of someone with bacterial meningitis, especially Neisseria meningitidis, and you were in close contact with their oral secretions. So you were suctioning them, you were intubating them. Those are the patients that you have to be concerned. If that happens, then you should get post-exposure prophylaxis. We can certainly let you know from the hospital what we find on the spinal tap, what's going on with that, and then so the post-exposure prophylaxis for that is typically just 1 dose of Cipro. So those are what we just covered are the things where you need to think about getting prophylaxis, you need to think about acute things that are acutely going to affect what you do. The other things are things you may get exposed to in the course of your job and or things you can immunize against, and we'll do a quick review on each of those. So obviously this time of year we deal with influenza and the common cold, so both are viral infections. We've talked a little bit about how influenza mutates and how the virulence of influenza can vary. So there are some years where influenza, so take 1918 where you had the pandemic flu, it was very virulent and it affected young, healthy people. So you had large numbers of young, healthy people who were either taken out of the workforce and or dying because it was a rarely virulent strain that was also really easy to transmit. We'll see smaller scale epidemics like H1N1 a few years ago. Again, the symptoms are like most viral infections. Management is supportive, but immunization can be very helpful in both preventing your risk of getting it and preventing the patient's risk of getting it. Specifically, so if you have a year where the virus is very prevalent and very virulent, there's about, if you're unimmunized, there's about a 4% chance that you'll get influenza over the course of the year. Being immunized cuts that down to about 1%. In an average year, it's about 2% of the whole population gets influenza, and if you get immunized, that cuts you down to 1%. So those are small numbers, but another way to look at it is even in a common year, getting the influenza vaccine cuts your chance of getting influenza by half. So norovirus is a common viral infection. We often see this sometimes in schools, definitely in daycare centers. Nausea, vomiting, diarrhea, and abdominal pain, direct contact, and droplet precautions. This can also happen in a sniff, and the treatment is supportive. Measles is something that thankfully we see fairly rarely, and unless there's war breaks out in Northwest Portland, where you have a lot of unimmunized people, we're probably not going to see a lot of it. It's definitely something that they're seeing a lot of in Syria because you didn't have great immunization rates, and then when you get people crowded into refugee camps, it's very, very easy to spread. So it's highly communicable, spread by droplets as well as direct contact, and severe cold, fever, conjunctivitis, and then a rash. You probably heard someone use the expression like, that's a pretty measly looking kid, and that's specifically looks to this just miserable looking kid with this rash all over. They look awful. But with immunization, this is completely preventable. Mumps is a viral infection, also completely preventable with immunization. In unimmunized patients, you see it primarily in 5 to 15-year-olds. You get this painful enlargement of the salivary glands that kind of look like a chipmunk, and then later on it can also cause orchitis or swelling in the testes. And so they have earache, difficulty chewing, swelling. Again, completely preventable with vaccination. Rubella is a systemic viral infection. It is, in addition to the other viral syndromes, they typically have a fine pink rash. It's also called German measles. It's preventable with immunization. The one thing that you need to be cautious of with this is that exposure to rubella is very dangerous for a pregnant woman, not for the woman as much as for the fetus, because it really affects fetal development. So that's something to be cautious of if you're pregnant, if you're around people who are pregnant. The immunization checks it, and when women establish prenatal care, they'll typically check their status with that. RSV, or respiratory syncytial virus, is a common viral infection. We're about to get into the season for that, and this is the most common cause of bronchiolitis in infants and young children. It can cause pneumonia as well. It can be difficult to differentiate from other things. The thing that especially the pediatricians especially talk about with bronchiolitis is that you have shifting exam. So that's the kid where in the house you kind of hear them wheezing like in the right upper lobe, and then you move them into the ambulance, and then they're wheezing in the left lower lobe, and it kind of moves around because they're kind of moving these little mucus plugs around. The management is supportive. Occasionally kids who have good follow-up and just need a little bit of oxygen can go home on oxygen, but kids who are requiring more oxygen, who have respiratory distress, typically get admitted. Pertussis, or whooping cough, is something that we're definitely seeing more of. So pertussis can be fatal for children, and children are not fully immunized against it until they're typically over about 8 months. And so pertussis vaccination is something that we recommend you be up on when you're working around kids. Now, if you've gotten a recent tetanus vaccination, we now give the combined tetanus and pertussis vaccination. If at all possible, you want to avoid this as an adult, because the way you get this as an adult, you don't die from it, but you kind of wish you died, because it typically causes a month to 2 months of paroxysms of coughing. That cough where you just can't catch your breath. And you can treat it, you can give someone azithromycin for it, but that just makes them less likely to transmit it. You're still going to be stuck with that cough for 1 to 2 months. And so it's really, it's again something that you can prevent with vaccination. Okay. And then tetanus is an ever seen patient who's had tetanus. It's again very rare. This is these whole body contractions, opisthotonus, are what's typically described with tetanus. So standard practice is to get a booster every 10 years. If you have a dirty wound, we'll typically update it after 5 years. So these are typically patients that we see. And if there's any question about it, we'll update it in the emergency department. But it's not a time-critical thing. There may be patients that you see who have a laceration, doesn't need care right now, or even a puncture wound that won't need sutures. But if you're releasing them, there's someone who should talk to their primary care doc about making sure their tetanus status is up to date. So OSHA required immunization, hepatitis B for the reasons that we talked about, the Tdap, that's the tetanus, diphtheria, and then acellular pertussis, annual flu vaccine, polio vaccination you probably had as a child, and then recommended hepatitis A can be vaccinated against measles, mumps, and rubella. The MMR vaccine are things you typically got as a child, and then zoster vaccine for elderly patients to prevent shingles. So just to refresh yourselves on protocol for pre-hospital exposure, if there's a known or suspected exposure, follow your agency's standard operating practice. Do not wait to report. And having been in this business for a while and having seen people, I know there's a hesitance to report. You're like, did I do something wrong? Was I really exposed? If there's any doubt in your mind, you should report. If this is a job-related injury, you want to protect yourself. And then you'll get prophylaxis and/or treatment as recommended by that. but particularly for those things that require fairly quick prophylaxis, so HIV, hepatitis C, meningococcus, those are things where you want to get post-exposure prophylaxis fairly quickly. If you don't know about the exposure, so say you bring someone in who just looks generally ill, we later find out that that person had meningitis, then on the hospital basis, we will reach out to contact you to get you the necessary prophylaxis. As far as minimizing your chance of illness, we've hit on this before, but there's nothing as valuable as washing your hands. And unless you actually have particulate matter on your hands, washing with alcohol is incredibly effective. So as long as you're getting the crud off your hands, wash with alcohol, and that definitely decreases your risk of infection. And without actual stuff that you need to get off your hands, it's as effective as soap and water. I touched on this already, so we recommend the influenza vaccine. If you're not having the influenza vaccine, then we'll ask that you wear a mask during times when you're contacting patients during the flu season. And then these are the numbers that I referred to before. So it's not magical, but it definitely reduces your risk of getting the flu. Okay. And so that's all that I have about infectious diseases. Let's do a quick refresher on opioid dosing, and then we'll take another break after this, and then we'll do case review and the last items. So this is from the agency medical directors group from the state, and these are the indications for pain control and dosing. So remember fentanyl, remember your dosing, remember slow injection. Rapid injection is where you get a wooden chest that's been described with fentanyl. Very rare, but very disconcerting. And so the indications for acute pain control: cardiac chest pain, abdominal pain where you're suspecting dissection or an abdominal aortic aneurysm, musculoskeletal pain, burns, chest wall pain. You're aware of the side effects, but the recommendation from the agency medical directors group is that we avoid this for acute exacerbations of chronic pain. These can be very difficult to treat. It's something that that we definitely deal with in the emergency department. But if you've got someone who's got chronic pain and then broke their arm, it's very reasonable to provide pain control. But if you're dealing with someone who has an acute exacerbation of chronic pain, those are the situations where I would avoid pre-hospital narcotics. Questions about that? Just a brief reminder about Narcan. We've had a couple of issues with that. So Narcan, if someone has respiratory depression or apnea, then you can go 2 milligrams intravenous, intranasal, intramuscular with a repeat times 2 if you suspect that they have a large ingestion. But if the patient is not having respiratory depression and or if they're opiate dependent, these are the times where it's really helpful to titrate your Narcan in. Who's had someone get either violently ill or combative after giving them a little bit too much Narcan? So it's not, you're not going to kill them by giving them too much Narcan, but you're going to make your transport a lot less comfortable for you. We definitely had patients require restraints, pull out IVs, get much more difficult because they get so agitated. So these are the situations where you can titrate it in. Even with someone who has respiratory depression, remember the Narcan is something that you're doing so that you don't need to bag. So if you think it's an opiate overdose, you can give them the Narcan. But if there's any question about how quickly you need to give it, you can always bag them until you can get them to breathe on their own. The ideal situation is where they're breathing on their own, but they're still nice and calm, comfortable. Why don't we take another 5-minute break now, then we'll go into ALPS and then case review. So the first thing I want to say with respect to ALPS is a thank you and a congratulations to you. So I was at the scientific review meeting for the metro area 2 weeks ago, and ALPS is, of all the enrollments that have come from the metro area, 46% have come from Clark County. It's been, so one day I think we're going to have an answer to whether lidocaine, amiodarone, or saline is better for recurrent VT, and this group is going to have a big part in answering that question. So you're going to affect practice, not just here, but all over the world with what you've done with this. But I think you've done a fantastic job. The other things that the coordinators wanted to pass on is that as compared to previous trials where they were getting maybe like 20% of the PCO files, they're getting upwards of 80% of the PCO files from these arrests. So much better than expected. Really helps them to get high quality data analysis on this. So I think just a system-wide kudos. I think the system has done a really good job of implementing this. The Data Safety Monitoring Board is meeting in the next couple of months to do preliminary data analysis. So we'll figure out, do we have an answer yet? Are we going to keep going? But the most important thing is that overall, nationally, enrollment has lagged behind where we want to be. So we just want to make sure that we're not missing any cases. So just as a reminder, so this is for non-traumatic out-of-hospital cardiac arrest where you have vascular access and persistent VF or VT after one or more shocks. So the way that coordinator is saying is 2 shocks, think rock. So the exclusion criteria, if they got open label amiodarone or lidocaine, so say it's the person that you were treating for, for a stable VTAC with a pulse, got amiodarone, that person cannot then be enrolled into this study. If they have a known hypersensitivity or allergy, no protected population, so prisoners, minors, pregnancies, obviously trauma is an exclusion criteria, and then patients who have a no study bracelet. So what counts as a shock? Anything that the agency is administering, a first responder with an AED, obviously any ALS delivered shock, and any public access defibrillator or other agency that shocks. That's the first, that can be counted as the first shock. So ICD shocks do not count. So what is persistent recurrent VF or VT? So anyone who has VT but needing CPR after the first shock. And so if you are thinking about giving the antiarrhythmic drug, that's when you would give the ALPS drug. So preferably, we're going to give these as soon as possible. They can be given immediately following epi, but you have to flush the tubing first. And this is something that's being watched very, very closely. So if it comes back, you're going to continue on with the protocol. If you give those, you get that again, then you're going to shock again. If they're still in VF or VT, you're going to give syringe number 2. So what about late occurring? So say you're deep down into an arrest and then you're getting it. Anytime if there's been one shock and you have another episode of VF or VT, that applies. And so say you shock them once, you get them into a sinus rhythm, they go into VF or VT again, that's when you want to give the ALPS drugs. So first dose of this study is 2 syringes, so syringe 1A and syringe 1B. Second dose is syringe number 2. And in small persons, then you're going to use 1A first and then 1B as the second dose. And then if it persists after you've given 2 syringes, you can use other antiarrhythmics. You can use additional shocks, just not open label amiodarone or lidocaine after you've given the ALPS drug. So if the syringes are broken, the patient is excluded from the study. you can go back to your typical protocol where you'd use open label amiodarone, give your normal doses. If you've already given one syringe, then you find that the next syringe is broken, then they're excluded. You'd go back to your open label drug. You do not want to give more than 200 milligrams of lidocaine, and you can use amiodarone at the normal doses. So most likely, if it's broken, you're going to give open label amiodarone. So the ALP syringes are not compatible with the Lurlock, so you need to use this clear link adapter. You put it on the tubing before you attach the syringe, and then you attach the syringe to the clear link with a half turn. Here's where the syringe goes, and then that goes on. So here's the clear link adapter. Okay. So after you enroll a patient, call the number as soon as you're able. Where the Resuscitations Outcomes Consortium is required by law to notify patients or the families once they've been enrolled, and then obviously you're going to notify the receiving hospital. So your documentation is what you would normally do for cardiac arrest. Having the CPR process file is incredibly helpful to the data analysis. Please upload that. And then timestamp each dose, whether that's having someone record it or ideally stamping it on the monitor. And then you're going to include the study drug kit number. Okay. And the last thing is, if you're coming across any broken, where the tape is open on any kits, you call the number, they can come out and replace that. If the tape is broken on one side, they may just be able to retape it. If it's broken on two sides, they'll replace the kit. Any other questions about ALPS? Okay. So some interesting cases, and as much as possible, I want you to put yourself in the situation of the treating paramedic and think what you would do. So case number one, is there anyone here who is on this case? Okay. So a patient who fell off a 12-foot ladder on the side of his house. He hit his face coming down the ladder, then fell to the ground, tried to break his fall with his arms. He initially said that he didn't remember the fall, but then he remembered that. He's complaining of facial pain, left and right wrist pain. He's bleeding from his nose and his mouth profusely. He walked 30 feet to a bench so he could try to control that bleeding from his face. And then you find him sitting on the bench. He's in the tripod position, alert and oriented. His area is open with him sitting up. He is, but there's a fair amount of coughing. He's got rapid breathing. His lung sounds are clear. So think to yourself, how would you package this patient? What's that? Sitting up. And why do you say sitting up? And so here's your exam. He's got instability noted in the right orbit of his cheek, profuse bleeding, no fluid out of his ears. His neck is non-tender, chest and abdomen are normal. He's got a little bit of tenderness on the left side. Back is non-tender, and extremities have those bilateral wrist injuries. And so the paramedics here put him in the C-collar, and they kept his head elevated. He was anxious about having the C-collar on, and so he kept to remove it. They adjusted the fit, they patted him, but kept him upright. He's moving around, but he's got no pain in his neck, no paresthesias. He does say he feels like he's hyperventilating. He kept on wanting to hold this towel up to his face. It was difficult for them to get blood pressures. These are the things that you've seen before. He's got GCS 15. You see his pulse of 82, strong radial pulse. Respiration's 32. Saturating 100% on room air. Initial blood pressure that they were able to get was 90/40. Comes up to 107/61. Excellent documentation of a neuro exam. So he was in the hospital for 10 days. He ultimately had comminuted displaced Lefort 3, so his whole midface was floating. And then right and left distal radius fractures, which among other things make it really difficult to take care of yourself in the bathroom. And so he ultimately had a tracheostomy just because he was requiring a lot of surgery to fix this, specifically the reduction and fixation of his Lefort fractures, close reduction of his nasal fracture, and then he had a laceration over his philtrum. Questions about that? Other thoughts? Yeah, he was a trauma team entry, the fall because of the airway issues, and so he was, and so in the setting of the emergency department with a lot of extra hands on deck, he was intubated there. A lot of blood in the airway. There are certainly situations where you might have been forced to intubate this guy in the field. Certainly, if you were obtunded, then this is someone you could intubate in the field. But I think this is a difficult case because you can certainly make a case that this guy has a distracting injury. You should be putting him on a long backboard. But I think the fact that he was ambulating and the fact that he really did better upright to manage his airway is a good example. And that, this is not an uncommon thing to happen, especially with a gunshot wound to the face. These patients will manage their own airway as long as you let them sit up. And so, kudos to the crew. I think this is very well managed. If you are more nervous about the spine, but you need to keep them sitting up for other reasons, what other tools do you have available? Yeah, a KAD is another way to approach that. Sounds like this guy's pretty anxious, and this guy is clearly ambulatory with a normal neuro exam. Okay, so again, put yourself in the paramedic situation. So there's a patient sitting in a truck at the end of a dead-end road, oriented, speaking in quick sentences. The family says he's got insulin-dependent diabetes, hadn't eaten all day, he's pink, warm, and dry, doesn't feel well, but doesn't want to get out of the truck. And so they eventually are able to get him over to the MICU, and they find him to be wide complex tachycardia. Then he becomes very diaphoretic and agitated. He's flailing his arms around. They are able to get an IV and secure it. So his blood glucose is 256. Initial blood pressure is 154/74. Pulse is 166. And here is the initial EKG. So say you're faced with that in a field diabetic. What do you think you'd do with that? How many people would want? How many people would want to shock this guy? So he's diaphoretic, but he's alert and oriented. Blood pressure 150. Blood pressure 154/76. Heart rate 166. He's not having chest pain. Who would first? What are your other options besides shocking this guy? Amiodarone. What else? Yeah. So, and I do think in this situation where you've got someone who's got a normal blood pressure, I think those are all reasonable options. I think this is not someone who clearly falls into one pathway. This, although you're, who would call this VTAP? Yeah, probably not. He's got a left axis. There are no fusion beats. That said, if you have any question, it's probably, in someone of this age, it's generally more likely to be VTAC than to be a sinus tachycardia or an SVT with aberrancy. So this is what happened here. So the crew gave him amiodarone, 150 milligrams, and then he lost vital signs. Okay. He was given Versed and synchronized cardioversion. Did not respond to that. Another synchronized cardioversion at 150 joules. Still did not respond to that. And so in the hospital, ultimately got many more studies, was found to be sinus tachycardia, bundle branch pattern. He had UTI, and that's probably why he didn't convert with the shocks. So in this case, it ended up being a sinus rhythm with aberrancy. I still do think that those are reasonable. All the approaches that you outlined there are all reasonable. This is a very difficult case to handle. He also ultimately had an NSTEMI, went to the cath lab, had previous stents occluded. So very sick patient, very difficult case. I think but the other thing that's mentioned here, the fluid. I think the fluid is also a good idea because in your differential here is still, this could be SVT with aberrancy. It could be sinus tachycardia with aberrancy. It could be ventricular tachycardia as well. Questions about that one? Okay. So you're called code 3 for childbirth at the jail. It's a 26-year-old woman who's complaining of abdominal pain. By last menstrual period, her estimated gestational age is 33 weeks. She's gravida 1, para 0, contractions 2 minutes apart. She last prenatal care was in June. She's due November 11th. This is mid-October. Staff says she's crowning. Water broke earlier this morning. So just picture with your equipment, what you'd set up, what you get ready. So she had a normal uncomplicated delivery. Oral and nasal suction. She, after the delivery, had no other urge to push. Placenta didn't deliver on the way. Ultimately, in the emergency department, or in the OB deck, her placenta delivered. So in the EMS, the baby initially had a weak cry. APGAR was 5 at 1 minute and 8 at 5 minutes. But with stimulation, the baby improved, did well. They're both transferred on the cot for comfort. And baby did well. They ultimately went up to the labor and delivery floor, and both did well en route, and both were discharged 2 days later. So the complicating factors here were the mother had abused drugs, had no prenatal care. We were pretty unsure of the dates. They ended up thinking that the gestational age was probably about 34 weeks. So with those complications, otherwise your average field delivery, but it's something that we don't do that often, and I think it's worthwhile to just take a second to picture where all your stuff is and what you would do with that. Yes. Oh, really? No. That's unfortunate. Yeah, it was a difficult way. Junior, who would? And you, who was? Yeah. Where? Who was the baby with at that point? Who was taking care of the baby at that point? So to move on to a happier case of adult cardiac arrest. So was anyone on this call PEA arrest, someone arrested suddenly and with a history of throat cancer? Okay. Do you want to describe what you saw? And yeah. So, yeah, a little bit. Okay. 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 So AMR arrives on scene. Vancouver Fire is doing CPR. The paramedics attempting to intubate. This is very, very difficult to visualize with different tools. No obvious landmarks, no cords identified. Ultimately, the decision was made to do a surgical, but it's just documented as a cricothyrotomy. At this point, the patient had been without ventilations for 15 minutes. Because of the prior throat surgery, no landmarks could be palpated or viewed. So a 1-inch vertical incision was made inferior to the thyroid, 6/0 Shiley inserted, and a 4 to 6-inch blood clot was removed from the trachea. The patient had return of spontaneous circulation, was transported to PA South Southwest. So the typical things you'd see with a prolonged code. And so I think this is one of the most difficult airway cases that you'll ever face, where you've got someone who, because of prior surgery, is very difficult to intubate from above, but also very difficult to intubate, and very difficult to cric. And ultimately, this is going one ring below was what happened here. The paramedics here went one ring below. They were successfully able to ventilate. So I think, this is, again, I think one of the most difficult calls you will ever run. That said, what ultimately happened here is the patient had an anoxic brain injury and was ultimately pronounced brain dead. So I think this brings up a couple of things about cric. One is the hardest part is the decision to do it. And when you have 3 failed attempts by an experienced operator, you're in a failed airway situation. And that's why you need to go to something else. You can either try to ventilate with a supraglottic airway, or then you have to go through the neck. Remember that you have, particularly in a difficult case like this, you have online medical control as a resource. And I think that this is definitely a time to contact online medical control. This is a procedure that's potentially life-saving, but has to be done in an expeditious manner to make the difference for the patient. And I just say particularly when you're doing something that falls outside the realm of what we normally do, is a time to involve online medical control. Do you have anything else to add to that? Yeah, I mean, this is the only, I think the last thing that springs up is that, you know, you're here, we spend this time together, you spend all the effort that you put into training, not just, you know, as a paramedic, you're not just running a cardiac arrest, going through the ACLS algorithm, but you're thinking about why this person is down. And kudos again to this group for thinking about this, recognizing that this was a hypoxic arrest, and the only chance that this person had was to get an airway, to get ventilated, and to do this. So, yeah, that'd be very, very impressive. But if you're going to do it, then do it. Make the decision and do it early. So I'm going to tell you briefly about Pulse Point. This is not. We've not distributed this to the public yet, and it's still undergoing beta testing. And so we'll talk briefly about this, and then we'll be done. So Pulse Point is an app that's available for iOS and for Android devices. So it allows bystanders that are CPR trained to be alerted to a cardiac arrest. Now,
it wasn't our idea,
yeah.
right?
Right. Okay. It is only. Right. Right. It is only for an arrest in a public place, and it is only when the bystander is within a few hundred yards of that cardiac arrest. So this has not been rolled out to the public yet. This is not being advertised yet. We want you to be aware of this. So one of the biggest predictors of surviving cardiac arrest is getting bystander CPR. Now, because of this only public place, only close by, it doesn't come with an app that lets a bystander, you know, also have red lights and sirens on the roof of their car. Right? This is only someone who can walk to something that's close by. But we need to see how it works in practice. There are definitely some counties in California that have been using it and have seen an increase in their bystander CPR rates as a result of it. It'll also tell you where the closest AED is. But this has not been rolled out to the public yet, but we wanted to give you advance notification of this. I can take questions now. I can also take questions after we wrap up. Okay. Thank you. Please do fill out the evaluations. We definitely look at it, and thank you for your attention.